Okay. I'm speaking on this topic because this causes high glycemic variability and causes a lot of problems with glycemic control. It might actually help some of your patients whom you've had difficulty treating. Okay, I'm a pediatric endocrinologist, but I do have some patients who are adults, maybe some elderly ones as well. What is celiac disease? Celiac disease is multi-system. It's triggered by ingesting gluten, which is just a protein in wheat, rye, and barley. What causes the problem? If you're not digesting this properly, the remnant peptides can cause an immune reaction. They get into the wrong place. In other words, if they get submucosal, can be asymptomatic in children and young adults. It can present with gastrointestinal symptoms, or it can present with things like short stature or systemic illness. But in children, it can also present with learning difficulties, behavioral problems, and sleep difficulties. And in European studies, it has been shown to be a cause of short stature in anywhere from 19 to 60% of patients in short stature clinics. Why is this important to us now? Is that while many of us who went through medical school used to think that this was actually very rare in Asians, the reality is that it might be something more that we will see more and more, and I'll explain to you why. But even in terms of classical celiac disease, while it used to be thought of as a very gastrointestinal disease, we now know that only about a quarter of patients will have GI symptoms. Half of them may have just very, very vague abnormalities in liver function, osteoporosis, gynecological problems even, and maybe 21% have no symptoms. Whereas as a pediatrician, I will tell you that many of these guys will show up with issues relating to growth and puberty. Even if you have no symptoms, if you later on develop high serology of celiac disease, you're going to have more mortality, more cardiovascular disease, more autoimmunity, and more cancer. So it's something that you cannot ignore. In terms of diabetes, it can actually cause problems with glycemic control, increase in the requirement for insulin on a per kilo basis, and actually poorer growth. An Egyptian study, children with positive screening needed higher insulin doses, had higher HbA1cs, more hypoglycemia, more recurrent DKA if you had celiac disease. And they might also have lower bone mineral density, as well as earlier retinopathy and earlier microalbuminuria by about 10 years. Right? So we were just talking about CVOT risk in children with type 1 diabetes. So celiac disease, gluten intolerance is a cause of increased CVOT risk as well. On the other hand, the clinical features of celiac disease in type 1 patients may be subtle, atypical, or completely lacking. However, a gluten-free diet in type 1 diabetes patients improves the blood glycemic control and has a positive impact on biochemical parameters. Is it that rare? No, not really. Autoimmune thyroid disease in type 1 diabetes occurs in about 17 to 30%. Celiac disease in type 1 diabetes is about 6 to 8% on biopsy, whereas various serological studies show that the prevalence of positive serology is anywhere from 10 to 30%. And celiac disease risk in autoimmune thyroiditis actually is 4 to 15 times higher than in the background population. There are other environmental factors which may now be developed driving up celiac disease risk, and these would include the presence of pesticides or forever chemicals, the PFAS chemicals, in the environment. You can also get this increased risk from disruption to the microbiome, from the overuse of antibiotics and food derivatives, from the increasing prevalence of cesarean sections, and lower breastfeeding rates. In India, the increase in celiac disease has been corresponding to the annual increase in rise in antibiotic use. How do forever chemicals and pesticides affect celiac disease risk? There was a study from the Langone in New York. This guy called Trasander who actually looked at celiac disease and looked at the serology of the look at forever chemicals in the blood of people who had celiac disease versus people who did not. And they showed that actually, if you had increased pesticide exposure or non-stick chemical, like the stuff that you make Teflon pans from, you had increased celiac disease risk. And in boys, if you had fire retardant chemicals in your bloodstream, you had increased celiac disease risk. These chemicals have been found in many parts of the world. In India, they've been found in breast milk samples, in fish from your rivers, in surface river, and even deep groundwater wells, which are more than 100 meters down. It has been found in particulate air pollution. It has been found in your swamps, in the rural areas. Inside India, it has been found in the Himalayan regions and in Tibet, in snow. So I think the exposure of Indians and Indian children to these chemicals is high. This may change a lot of what we think about who is at risk of celiac disease. And I think it's important for you guys to look out for them. There are some guidelines on screening for celiac disease in the ISPAD guidelines and various other guidelines. They usually talk about screening at the start of the disease, and subsequently if you've got unexplained hypoglycemia. But I think you should look out for hypoglycemia. In any case, a recent study from ISPAD also shows that while it is being preached, it is seldom practiced in terms of screening. The gold standard for the diagnosis of celiac disease is the presence of villus atrophy on intestinal biopsies. But endoscopic biopsies are often impracticable or unaffordable, and not all pathologists are competent in actually reading these slides. So revised recommendations for celiac disease screening now include consideration of a serology-based diagnostic approach. This is also because in India, while 7 Indian studies have shown prevalence of about 13% of type 1 diabetes patients in India being seropositive for celiac disease, only 3% of these people actually had villus atrophy. This may not be because they don't have celiac disease, but it may be an issue with the timing of your diagnosis. Would you screen using TTG alone? I would not. I think it's important, if you do screen, to consider screening with a 4-test panel. What are these 4 tests? They are deamidated gliadin peptides and tissue transglutaminase. They all have 70, 80, 90% sensitivity and specificity. But while a lot of places have recommended the pure use of TTG IgA alone for screening, a recent study from Mayo Clinic in the US actually suggests that this is wrong. This is actually due to what we call bias in terms of how you treat the statistics. And if you actually look at the statistics carefully, TTG IgA only has about a 57% sensitivity and specificity. You should actually use other things. This is a study from Columbia University that showed that, yes, while people with biopsies positive celiac disease do have tend to have very high serology levels when you do test, some of these guys who have positive biopsies have negative serology. It comes down to 0. So it's important, right? Clinical suspicion might be more important than serological testing. And if you do test, I will tell you that in my own series of about 100 patients, TTG IgG and DGP IgA would be actually more likely to be positive in TTG IgA, which is seen more in Caucasian patients. This is a busy slide. I'm just pointing out why. But I would say to you that because it is expensive to test for serology for celiac disease, look for the clinical picture. In a study from North India, this was from near Delhi, The mean age at diagnosis of celiac disease in type 1 diabetics was about 13 years plus minus 5 years. And it tended to be diagnosed about 5 years after the onset of type 1 diabetes. How did these people present? They presented with short stature, anemia, weight loss, diarrhea, abdominal pain, glycemic variability. And if you actually picked up the diagnosis and removed the gluten from the diet, then 14 out of 16 patients would have reversal of anemia, weight loss, and diarrhea, with improvement in height velocity. These are all very important clinical outcomes. Gluten intolerance responses in people with type 1 diabetes might be similar to celiac disease responses. You can get an immediate high or increase in insulin requirement for the same number of grams of carb. And I would say 2 to 3 times more insulin is required. You can get initial hypoglycemia followed by hyperglycemia hours later due to delayed gastric transit time. Effects of gluten ingestion may last overnight or give you glycemic variability for up to 3 days. Some people don't get much tummy pain and therefore they tend to dismiss the situation. But remember the people who used to get hyperglycemia and recurrent abdominal pain. Some of these people actually had celiac disease. You can also use CGMS. This is an American patient who lived in Singapore for a while. She actually would just get spikes of glucose every time she had gluten in the food. No gluten, same amount of carbs, no spike. Celiac disease can be present at the diagnosis of type 1 diabetes. This is a French boy. He only showed up with TTG IgG, not TTG IgA. Within 3 days of stopping gluten, his insulin requirement came down. So he still had type 1 diabetes, but he became much easier to treat. And he told his mother, "Mother, this is the first time in 10 years I have not had abdominal pain." Okay. Celiac disease can present early in diabetes with glucose variability and poor growth. This is an 11-year-old child, very smart girl, but her symptoms would last up to 3-4 days after just one meal of gluten, chilies. This is an adult patient of mine. She was on a pump. She was a PhD, very, very good glycemic control. One day she called me up and said, "Doc, I've had funny sugars for the last 3 weeks. Maybe test me." And it turned out she had acute onset celiac disease. Right? So she had beautiful control for 20, 30 years. She had almost young adult children, very, very good control. HbA1c almost below 6%. Suddenly deterioration, sudden onset celiac disease. This is another patient of mine who was very, very good on a gluten-free diet. She changed her brand of shampoo. The shampoo had gluten. The sugars went haywire. This is another patient of mine. He presented in DKA. We found out he had gluten intolerance. We gluten. Thereafter, presenting like a type 2 with insulin requirements only during acute illness and on metformin. So why you test for celiac disease in type 1 diabetes patients is so that you can improve the quality of life and quality of glycemic control. You can get spontaneous normalization of serology. There has been studies from Turkey and from Egypt and from Saudi Arabia. But you will find that even if they get spontaneous normalization, these are also patients where if you take away the gluten, the quality of life and the quality of diabetes control improves. So celiac disease in type 1 diabetes can be obvious with very high titers from the beginning. They can be adherent and maintain a good gluten-free diet. They can actually have very high numbers from the start, or initial screening can be negative, and 3-4 years later, you then get celiac disease. You can have different positive markers over time. So this is one of my patients. She's actually, I've looked after her since she was a teenager, and she now has 2 normal adult daughters, normal teen daughters. So over time, different markers will come up. But I do want to emphasize gluten intolerance. Some of our patients, because they have lower intake of gluten, they may present as if they have only gluten intolerance. But if you follow them up over time, they end up with celiac disease levels of antibodies. But just a little bit of gluten will cause them to spike. And this is my Bangladesh patient. So he's type 2, he's on metformin, but every time he has a roti, first he will get a spike in sugar, and then he will get hypoglycemia. It is very consistent. Okay, so if you don't understand this, HbA1c, HbA1c is fine. But otherwise, if you look at this, you'll say, if you can actually take out your rotis, you'll have much better glucose. It can be quite a problem. This is a patient who was 14 years old. He was evacuated out to CME in Singapore because he had severe uncontrolled hypoglycemic episodes and hyperglycemic episodes. 3 days after taking out gluten, he had very nice blood sugars. Again, this is not somebody with very high numbers. He had intermediate levels, above zero, not quite celiac. So I stop here because of a lack of time, but the take-home message is celiac disease exists, screen for it. Celiac disease can give you glycemic hypervariability, look for it. Even if you don't have the possibility to do serological screening, CGMS or even SMBG can help you make the diagnosis because it's very simple. Give a meal of rice, give a meal of roti, look at the difference in glycemic control. Thank you so much.